Recording. So, good morning, everybody. Thank you for joining us again for our weekly CAT conference. We changed it around a little bit. Amir, thank you for accommodating that. And today, our session's by a good friend, Amir Kaki, who is the Director of Mechanical Circulatory Support and Complex Coronary Intervention in Detroit, Michigan. Amir's got an incredible experience with Impella, ECMO, really all types of MCS, but importantly also, managing the vascular access part, which I think we don't often put enough attention into. And so it's not surprising, Amir, when we see data like the ones that came out last year showing all these increased vascular complications. So I think the axillary artery is one we don't use enough. We've been using it a lot more here, and we have some specific questions, hopefully at the end, from some of our heart failure colleagues that we'd like to ask you. But thank you. You can take it from here. We look forward to learning from you, Amir.
Yeah, no, it's an honor and a privilege to present, and I commend you, Azim and Dr. Granada. I've been following you guys since this initiative started, and this is really a treat for your fellows, and hopefully other fellows across the country can learn from the expertise of this CAT conference. So with that said, I'm going to talk to you guys about large bore alternative access, particularly using the axillary artery, and share with some of the applications where I think it could help some of your patients. So here are my disclosures. I speak and proctor for Abiomed and do the same for Abbott. So some of this data you may not think is relevant, but this is just a little background on the prevalence of PAD. And so if you go back to high-risk TAVR patients, in the initial studies, which Azim was a part of, a third of the patients who had severe aortic stenosis had anatomic criteria that were not favorable or would not permit transfemoral access. And you got to keep in mind, in the early TAVR days, the sheath size were much bigger than we're doing today. And some of the reasons that these patients were femoral prohibitive were their vessels were too small. They had extreme tortuosity given, advanced age of most of these people, and had prohibitive hostile peripheral arterial disease. And as we take care of patients, I think everybody in the rooms have seen patients like this, particularly elderly patients for transcatheter valve, where you see extreme tortuosity, and patients who have coronary disease, cardiogenic shock, and oftentimes have peripheral arterial disease or disease in other vascular beds, and we've all seen this. So here are two examples where, going femoral would be a challenge and unfavorable. So what would we do for these patients? If you look at the TAVR data, the need for non-femoral access in partner 1, you can see it was a third of the patients. In partner 2A, that wasn't long ago, in 2014, it was still a quarter of the patients. And if you look at the data now, most recently, as I looked, it's about low single digits, 5% of the patients who get transcatheter aortic valve actually need an alternative access. And the reason for that is obviously, we're doing moderate risk patients now, we're doing younger patients, the technology has evolved, it's become smaller. And those are a lot of the reasons contributing to the fact that we're seeing the less need for alternative access in TAVR. That being said, if you do need alternative access, particularly for large bore procedures, percutaneously, what are your best options? If you want to do this totally percutaneously, we're not going to talk about surgical alternative access options today. Transcaval is a good option, and percutaneous axillary is a good option. And the focus of today's presentation is to talk about percutaneous axillary. But let's talk about cable. Some of the advantages of cable is that the sheath size does not matter. There's no limitations as opposed to percutaneous axillary. Given the size of most axillary arteries that are around 6 millimeters, there are limitations of what you could put in there. But in the cable, there's no limitations because you're going from the vena cava into the aorta below the renals, above the iliac bifurcation. And so the aorta could tolerate large bore devices. So you could put a 5.0 Impella in there, a 5.5 right now. If you wanted to escalate, you could do transcaval ECMO, up to 19 French cannulas if you needed to. You totally bypass the iliofemoral disease, regardless of how severe it is or the size. Some of the limitations of transcaval, for those of you who have done transcaval from a technical perspective as it relates to percutaneous axillary, it is more challenging. In an ideal circumstance, it requires advanced imaging because one of the limitations is aortic calcifications. And so in a shock or an ad hoc, when you need it emergently, it's not ideal. Some of the safety profile goes down. There is no dedicated closure device for cable, although we're working on one right now. And if you look at the seminal paper by Adam Greenbaum and Jack, when he published his first 100 cases, the risk of bleeding was high, almost 25% of the patients. That number has gone down significantly as the technique has improved. What about the advantages of axillary? So the average axillary artery, in a nice paper from McCabe and Raj Tayal showed that the average axillary artery for most patients is about 6 millimeters in the United States. The procedure is technically easy to do. The insertion time is relatively quick. I think I'll show you a paper where we did average deployment to MCS in the shock population was about 12 minutes. Bleeding risk is very low in the axillary, particularly if you have good access techniques. These patients could potentially ambulate, and I think that's an important advantage, particularly when we talk to our heart failure colleagues when these patients need prolonged support. It could be done in an emergent setting. The solutions to any complications that we have are percutaneous, and I'll share with you some of the complications that we've encountered. The good news is you could resolve almost all of them, I think, without exception, percutaneously. And when you talk about the reproducibility of teaching this as a technical procedure, I'll show you by the end of this presentation that technically it is very easy to teach, and once you teach it, results can be reproducible. Some of the limitations of axillary is we don't have dedicated equipment. There's lack of familiarity of the anatomy from the interventional cardiology community, but I'll submit to you by the end of this presentation, you'll know the pertinent anatomy that you need to know. The room setup is challenging when you talk to people their first time, but if you think about the days when we were transitioning from femoral to radial, that was also a challenge that you could overcome after a few cases, with your staff. And the other limitation is the size will not let us escalate from a CP Impella, for example, to a 5.0 or, to big ECMO cannulas, which we'll talk about briefly. If you look at some of the survival, this is survival data from the UK TAVR registry looking at different access points. And if you look at subclavian, this is surgical cut down, but in this particular case, we'll use this as a surrogate for axillary. And we have some data to support that. Comparing it to transapical, direct aortic, and femoral, what you'll notice is that the only difference is going to be is subclavian compared to femoral is the closest, with statistically not significant as a difference. But look at the mortality rates when you look at TAVR when it's done transapical versus direct aortic. So as a result of this data, when you compare them head to head, transapical and direct aortic have pretty much gone away. So subclavian cut down. Now we're seeing carotid as an access appearing to be safe, and percutaneous axillary. But for those of you that were around in the beginning of the TAVR days, alternative access surgical ones were apical and direct aortic. And because of the morbidity and the mortality associated with both of those approaches, they have pretty much gone by the wayside. What about the safety and the efficacy of percutaneous axillary for TAVR? And this is actually a really interesting paper that was written by Schaefer, German colleagues, in their first 100 cases that they did perc axillary for TAVR. But this has been the same in our experience here in Detroit. I think between me and myself and Dr. Schreiber, my partner who helped us really start the programs here in Michigan, is that we're at about 120 cases. But we had the same experience. And if you look at the use of stent grafts, which is probably the most common complication until you get, get some experience with the learning curve, 7 out of the first 25 cases required a covered stent. It's not really a major complication, but it's not ideal. But look what happens, as they got experience, and look at their last 25 cases when they went from 76 to 100 cases, only one of those patients needed a stent graft. What's notably absent here is major bleeding. If you look here, major bleeding is not is absent because it did not occur. So that's important for everyone to know. So we're gonna, let me see. So percutaneous puncture, we're gonna talk about the nuances of that to mitigate your complications, what kind of pre-closure techniques and post-closure techniques that we've established, the use of balloon tamponade, covered stent as a bailout, and the learning curve. There's a clear learning curve with this procedure, but again, you could overcome it pretty quickly. There is differences between the subclavian or axillary artery and the femoral artery. And this is just histology looking at a femoral artery of the same gentleman who's 75 years old. next to his subclavian artery. And the reason I like to put this slide up, because I learned in my early experience that the vessel is very finicky compared to, it's not as durable as a femoral artery. So when we're in there doing the perclose, you have to be a lot more delicate when you deal with the axillary artery. So that's one thing that's important to know. And the other thing is to know that if you look at people who have hostile iliofemoral disease that prohibits you to get access in their iliofemoral system, it's very rare that you'll encounter someone who has occlusive subclavian or occlusive axillary particular disease. And that is because I suspect because the different makeup of the vessels, so that they're not the same. When we talk about the size of the vessels, here's a nice paper that we talked about earlier from Raj and Jamie McCabe, looking at the average axillary artery. And what they showed was it's about 6 millimeters, slightly smaller to corresponding iliofemorals in those patients. However, much less likely to have disease if the iliofemorals had disease. If you look at the early experience in the U.S. with using this as a site, this was led by James McCabe at the University of Washington. Schreiber and I contributed a lot of cases to this. And this was in my early experience. And what we found is that if you read this paper, which was recently accepted in circulation, it's not published yet. But what you'll read is that there was a high percentage of covered stents. And if you look at that, the majority of those, even though the sites are not identified, were myself and Dr. Schreiber. And again, that speaks to the learning curve at the beginning, some nuances that we've learned. And as we teach this, more and more people are getting better at it and less need for covered stents. So we're going to go through a step-by-step approach on how to do this. And, if anybody has a question, feel free to stop me at any time. And then I'm going to show you some applications where we've used it actually in the last few days here at our institution, some interesting cases. In the past, when we talked about axillary artery, historically, it was referenced as a surgical cut down to the axillary artery. And prior to this, it was actually in the axilla. The vascular surgeons don't use that as an access site anymore because as you enter the axilla, they were noticing that the patients were starting to have a lot of plexopathies. And how do we avoid that percutaneously? It's very easy to avoid if you understand the anatomy. So if you look at this axillary artery in this cartoon, if you see the yellow, these yellow cords are actually cords of the brachial plexus. And what you see is the second segment of the axillary artery where my arrow is on the anterior surface of this vessel is devoid of plexus cords, okay? And that's why it's going to be really important that we stick there. That's one of the reasons why you don't want to be too distal, and I'll tell you some other reasons why, and you don't want to be too proximal because you invade the chest. So how do you understand exactly where the second segment of the axillary artery is? We'll be able to show you that angiographically is the easiest way. I'll show you some of the key vessels that you need to be able to identify so that you could avoid brachial plexus injury. So how do you prepare these patients? I like to put the arm out at 90 degrees. It straightens out the vessel. If you talk to Jamie out in the University of Washington, he has the arm in like a standard radial. I think it's much easier when you put the arm out at 90 degrees, and we'll show you what happens when you put it out there. If the first thing you do when you get axillary artery access is that you have to get ipsilateral radial access, okay? So it doesn't matter the indication, be it TAVR, be it cardiogenic shock, be it high-risk PCI, be it ECMO, you have to get a radial access before you get axillary in the same arm. So in the beginning, in your first few cases, I would use the femoral artery to help facilitate access and the femoral artery to help facilitate closure. As you start to get more facile, or if you have really good experience with endovascular skills, you could do this one arm using the radial artery access to help you get access and of the axillary, and using the radial artery to help you close. But in the standard early experience, this is what I would recommend. So here's a patient. You just take a JR4 catheter, do surveillance. This is in a shock patient where it's ad hoc, where you don't have advanced imaging. And you survey both axillary arteries to see which one is favorable. And so the thing is that What I would recommend is avoid the left axillary if the patient has a lima. I would also tell you to avoid the if the patient has a device like an ICD or a pacemaker on the left, I would avoid it. Although we have done some cases like that, there isn't a lot of data. But if the other side is just as suitable, I would avoid it. And the other things I avoid is AV fistula. So if someone has dialysis fistula on one side or the other, I would avoid it. You potentially could do it if you didn't have any options, but again, we don't have a lot of data to guide us. It's not a total absolute contraindication. So this is a small cartoon, and I'll show you the angiogram that correlates with this, but some of the things that's important to know is you see segment 2 of the axillary artery, and across segment 2 actually is pec minor. And so you are going to be going through a muscle plane when you get to the axillary artery percutaneously. Segment 1, you're going to start to see you start getting close to the chest, intrathoracic, and you don't want to do that. And the third segment, the distal one, 2 reasons why you should never stick there. Number 1, that's where the plexus is. And number 2, you could see this artery that comes off called the circumflex humeral. And the circumflex humeral supplies the humeral head. And what I'll show you at the end of the presentation as we're dealing with complications, if you have to use a covered stent, which is possible, that may happen to you in particularly in your early experience, there's no clinical consequence that we're aware of if you deploy it in the second segment. If you deploy it here, where you get access and you can't get hemostasis, you're at risk of developing avascular necrosis of the humeral head. So you really never want to cover this branch. So this is going to be your distal boundary, and your proximal boundary is going to be the chest wall. We're going to show you that on an angiogram, and here it is. So if you look here on this angiogram, you can see the chest wall by seeing the rib cage. So here we are, anything in medial to the rib cage, you're in the thorax. And the problem within the thorax, again, if you're bleeding, number 1, it's hard to identify. Number 2, it's hard to treat surgically. Percutaneously, it's the only way to really treat it. So you don't want to invade the chest. It's a very hard access point. Second segment is here. You can see it, and it's ideal because you can see there's no meaningful branches. There's no cords of the plexus. And here's the distal. So what you'll notice is the circumflex humeral in most patients and this vessel called the subscapular run in the same plane, north and south. So here's the circumflex humeral. You can't see it. I'll show you on the next angiogram. And here's the subscapular artery going south. You don't really need to know all these other small arteries. The most important reference point is going to be the rib cage and distally those vessels that I'm going to show you here. So again, here's what you need to know if you're going to do this. Here's the circumflex humeral going north. Here's the subscapular coming south. This little green box, and you could actually extend it a few more millimeters proximally, is what I call the sweet spot. As you start to get here where you see the chest wall, this is where you get intrathoracic, and you don't want to be there. So why do you want to specifically stick right in this sweet spot? There's several reasons. Number 1, it's compressible. If you don't believe me, when you're doing this procedure and you have a large bore sheath and you're doing exchanges, hold pressure, and you'll see that it's compressible. I'll show you an angiogram with the largest perf that I've had where we held pressure as we were preparing the cover stents, and we did an angiogram just to demonstrate that it is a compressible site. Although you can't appreciate it here, it's compressing against the second rib is usually where you're pressing against. Reason number 2, we keep belaboring the point, but it's important that you're far away from the brachial plexus. And number 3, you're never invading the chest, and so you don't have a risk of pneumothorax. So you don't want to invade the chest for pneumothoraces or hemothoraces. What you want to do is stay in the second segment. So for that reason, that's where you want to stick. So how do we get access? Okay, these are the nuances that took us a lot of cases to figure out. So I like to get angiographic guided access. If you talk to Jamie, he does angiographic with ultrasound, and you talk to Raj, he does both. I don't use ultrasound, and young fellows who are in the audience, you probably should, particularly those who are facile, but I would not recommend using ultrasound alone. You should use it in addition to iterative fluoroscopy. So what I like to do is I get an angiogram, and you could do this from the radial or the femoral. My recommendation in the beginning is go from the femoral because you're going to use it to close. And here I could identify all the meaningful anatomy that I need. So here you see the circumflex humeral going up. You see the subscapular going down. So you know this is the distal segment. You can see A2. which is a long, clean segment. And here you can see A1, you start to get proximal to the chest, okay? A few other nuances about this slide that's important. Number one, if your patient has CKD, you don't have to use an angiogram. You could just put a wire in from the leg and target your wire and use ultrasound. Uh, Caveat number two is if your cath lab, as most cath labs do, have the feature of roadmap, what I do is I roadmap this. I use 3 or 4 cc's of contrast, and I set a roadmap, and then I stick under fluoroscopic roadmap. The other thing that's important, do you see how the needle, so important things to facilitate a more successful hemostasis is the plane of the needle, and you can see you want to be in the same plane of the vessel. So sometimes I'll take a marker and I'll draw, the plane. The other thing is the angle of entry is really important, although sometimes the vessel's deep and prohibits you, but I like to get an angle of about 45 degrees. If you start getting at 90 degrees angles and you get kinks in your sheaths, particularly in the 6 French sheath that you put in early, the likelihood of having successful hemostasis is very low. So angle of entry and the plane of entry is really important. And here's the angiogram. After we get angiographic guided access, and you can see, look, there's a subscapular artery. We're exactly where we want to be in the sweet spot. We haven't invaded the chest. I take an angiogram, and you can do this with your 4 or 5 French sheath to confirm that you're in the right spot. It's very forgiving. If this is not an ideal spot, you can pull out, hold manual pressure. It's rare that that's going to happen to you because you're doing this under angiographic guidance, okay? So here's a case that we did for TCT, and a couple of things that I want to show you on this, some of the nuances. This is a patient at CKD. We used a J wire to save contrast there. We stick it with a micropuncture. You can see under direct guidance, you can see number one, the plane. I'm in the same exact plane as the vessel. You could tell by the wire configuration. We stick the vessel at the angle that we discussed, ideally 45 to 60. You try to avoid acute angles. And the wire goes in, and we'll pull away our catheter. Let's see, we got stuck. But so the wire goes in, and that's how you get the access. So what I want to show you, after we get the access, what's important to do is keep in mind that you went through pec minor. So because you went through pec minor and you're with a 5 or 6 French system, sometimes the Perclose wouldn't go in our early experience. So what I recommend is taking a 7 French dilator, dilate your tract before you do the Perclose. Then you do put Perclose 1 in and Perclose 2 in your standard fashion that we all do for a large bore in the femoral artery, with the only nuance being keep in mind that the vessel is very delicate. So sometimes if you have a tendency to get heavy-handed with the femoral artery, you have to make a conscious effort not to do that with the axillary artery. Again, it's a lot more delicate and you have more risk of perforation. If you look at how do we deploy the large bore sheath after we do the pre-close, and I think this holds true for the femoral, depending on what stiff wires you have at your disposal in your lab, my recommendation is using one of these 3 wires, a Lunderquist, a Supercore, or Amplat Super Stiff. And what we do is I'll put an 8 by 25 centimeter sheath and distally, and then I put my stiff wire so that it doesn't have to negotiate the subclavian and the axillary artery. I put it into the root of the aorta, and then I deliver the large bore sheath. So that's an important nuance step as well. And this is a slide I just like to show people, because if you look at the hands here, look how gentle we're pressing. It does not require a lot of force, despite the fact that you're going through a muscle plane. And the key is that we have a stiff wire that's in the root of the aorta. So that's keep in mind. So you should not be pressing very hard in the axillary artery. That's the reason I like to show that. This happens to be an Impella case, and the vessel is very tortuous, but you can see you could push, pull, your co-operator or assistant could pull the wire as you're advancing, and you could overcome that. Sometimes this could be technically very challenging, and so that's why I like to do the surveillance and try to take the side with less tortuosity. What about when you leave your Impella in place? I'm going to show you some slides or some videos that are historic significance, but we don't do this anymore because we've learned better. This is a patient who had cardiogenic shock, who had hostile iliofemoral disease. And what you see there, the blue towels, is us preserving the Perclose sutures and stents, sutures and utensils. So when the patient comes back, we could use the same ones. If you look at, we published our experience on this. Is there a risk for infection with delayed perclosure? And the answer to that question is no. We did not give prophylactic antibiotics, but all we do is use betadine for the IFU for the closure device. What happens if you're going to keep the Impella in, or the ECMO cannula in, or any kind of large bore sheath in for whatever clinical reason? You have to assure that you have flow to the extremity. And it's going to happen depending on the size of the sheath that you're using, where you have to keep it in and the arm could be ischemic. And so how do you overcome that? So if you get in a situation of life versus limb, you know, there's several things that you can do, but I'll tell you what the easiest thing to do is. This is our early experience.
Here we have a brachial sheath. What we're going to do is we have a male-to-male connector. We're going to open this, okay? And now we're going to open here, and you're going to see, and that's you have an axial brachial bypass external.
So you don't have to do that anymore, and I'll tell you why. Here's another one. This is an internal brachial bypass. This is a case I did where the patient had an Impella in. We peeled away the sheath. She was still occlusive. She didn't have any other good access points. And so what I did is took the femoral artery. I put a glide catheter into the brachial artery, and then basically blood is going to come out. You can see blood is coming out of the femoral artery sheath, going into my glide catheter. My glide catheter is at the brachial, and the proof is in the pudding. Do an angiogram through the brachial, and you can see that the hand is being supplied. Well, you really don't have to do that anymore because of this.
Connector will start to flow here forward, and then by opening the radial axis, the flow comes from the large bore side arm to the radial and the distal.
So this is important just to show you guys. So this is why it's so important to get radial access on any case. Those two other techniques that I showed you are technically very challenging. They're cumbersome and not very reproducible. If you're going to get axillary artery, even if it's for a case where you know the sheath is going to come out like in a TAVR, I always recommend getting ipsilateral radial artery. If you lose femoral artery, if you lose the sheath, whatever, you always have a bailout. But if in the shock population, particularly as it relates to ECMO and Impella and MCS, sometimes they're going to be exclusive. If it is, it's no big deal. You have a male-to-male connector. You hook up from the sidearm of your large bore access site to the radial artery, and that supplies your arm for the duration of the MCS implantation. The next important thing is, how do you close these large bore holes in the axillary artery? My recommendation, again, in the beginning, you know, with the exception of if you don't have the option because the patient's anatomy is not suitable, or someone who has very advanced endovascular skills, you could do this all from the radial artery, but I'll show you how we do it from the femoral. What we'll do is what we did really is parlayed all of our skills that we learned in the femoral artery and applied them to the axillary artery. So, you know, we're still old school. Myself, I can speak for myself and Schreiber. You know, when TAVR started, we were using a lot of up and over. The guys in Columbia taught us that dry closure. And to this day, we still use dry closure on 100% of our large bore cases. So what we did is we took that technique and applied it here. And here we have a balloon that's in the subclavian artery. And what we have is a large bore sheath in the axillary artery, and we have a transducer hooked up to the large bore sheath. We blow this balloon up until the large bore sheath transducer is blunted, that waveform, and then at which point we deploy our Perclose 1 and your Perclose 2, right? Here's the paper that I referenced to assure everyone that leaving Percloses in, so long as you keep them sterile and you use sterile technique when they come back with betadine, that this is a safe strategy for delayed hemostasis in people who have large bore access sites. We apply the same thing to the axillary. So after you deploy your Percloses, we take an angiogram under subtraction. In this particular case, you can see a little extravasation on the superior part of the axillary artery. We take that same balloon and we blow it up at the arteriotomy site. And you achieve hemostasis. Usually we leave it up for 5 minutes. This is an interesting case where this is one of the largest perforations I've seen. And this was iatrogenic because, when I told my assistant to go up to 2, they went up to 20 on a balloon tamponade. And this is what we saw. A very important thing to show you on this, we did an angiogram, and with me holding manual pressure, and the proof is in the pudding. with an angiogram, you could see, despite this being a large hole, that we were able to maintain hemostasis until we got the covered stent ready. That's number one. Number two, if you look at our access site, it's in second segment of the axillary artery, what we talked about in the beginning. And you can see here the vessels that we talked about, the circumflex femoral going north, subscapular going south. The hole is proximal to that. And here I take a Viabond. I like to use self-expanding covered stents in the axillary. And look what happens when we deploy the Viabond. Here's our final result. But what we have is, you know, hemostasis is achieved, which is great. But more importantly, we have preservation of the meaningful vessels that we talked about at the end. And you can see that the circumflex humeral is still going north and the subscapular coming down. And I think so it goes back to the point why it's so important to get really good access at the beginning. This is also not recommended anymore. In our early experience, we didn't know any better, so we were concerned about embolization to the hand. So we routinely did that in probably our first 50 cases. We realized that that's unnecessary unless the patient has some type of symptom. So we don't routinely do angiography of the distal extremity anymore. In summary, there's a few things the axillary artery permits you to do. You could potentially sit up in the ICU. If you're a shock patient, you could have your right heart cath coming in through your neck, potentially ambulate. And if you talk to our heart failure colleagues, this is a tremendous advantage, whether it be balloon pump or Impella. Allows for bridge to recovery or definitive therapy. I feel like it's better, at least in the shock population, compared to other alternative access because of the fast insertion time, lower rates of infection compared to femoral, and patient with transcable is going to have to lay flat and the risk associated with that. And technically, it's the least challenging of the alternative access. And this is more to the fellows. And this is what I tell my fellows, you know, techniques and equipment for large bore access continue to improve. However, large bore access is here to stay, at least for the foreseeable future, given what we're doing in structural heart and MCS. Although they're trying to miniaturize them, they're still a large bore. In my opinion, it's incumbent on for interventional cardiologists to have these skill sets to rapidly and effectively deploy large bore alternative access, particularly for MCS. If you're someone who's taking STEMI call and taking care of a shock population, it's not uncommon that you're going to have patients who have hostile iliofemoral disease, and this is an important skill set that you could potentially save your patients with. This is a toolbox of what you need to get in and out in a rescue toolbox. And again, you'll have the slide. These are some of the publications in our early experience, some step-by-steps that you can have access to. And here's a paper which I'll refer to at the end. So I want to show you about a few cases, and then we'll open up for discussion. And this is a case that we did. Actually, this is a case that I did a week ago, Monday. So this is a 84-year-old gentleman, same-day surgery for hybrid transcatheter valve implantation. He was scheduled for left perc ax. He had his vessels. I'll show you his iliofemoral vessels. So basically, this guy was symptomatic with aortic stenosis. And here's his pre-TAVR workup, okay? And he had an annulus. He needed a 29 valve. And you could see he has heavily calcific disease, but more concerning is that he had really small iliacs. You could see on the right, the minimum was 4 millimeters. And on the left, we had 4.6. And so they were actually too small. So sometimes you're going to encounter this in your TAVR patients. His axillary artery was bigger, which is rare, but was good for us. And what you see here in this particular case, this is a sheath coming in from the right. This is just a JR4. And I surveyed the axillary. It was good. We deployed the TAVR. This happened to be an Edwards case last week. Everything went well. And following successful deployment of the valve, I want to show you what happened here. And so you could see that this is after one Perclose, patient has some extravasation. Nothing really serious that would warrant covering with a valve. And so we had our guiding catheter here. We took our balloon up. We left the balloon up for 5 minutes and take another subtraction angiogram. And you can see we have total resolution. This patient went home actually the next day. So that's a great application. Here's another one. This is recently that we did at our institution, 59-year-old gentleman, type 2 diabetic hypertensive. He's a smoker, presented with chest pain. In the EMS, they activated the STEMI, so we were waiting for him. 3rd-degree heart block. Here's his tracing. You can see he has marked ST elevation in his inferior leads. Upon arrival to the emergency room, a point-of-care ultrasound showed he had an EGF of 5 to 10%, but he had a good blood pressure of 163 with a very low heart rate, of 31. He had 1+ femoral pulses, despite having a blood pressure of 163. This was another one of the operators here. I was called in. I'll tell you at which point I was called in. So the patient was started on vasopressors. A TVP was put in, and as they're putting the TVP in the cath lab, the patient became unresponsive. He fibrillated. ACLS protocol was initiated. Multiple rounds of CPR. If you talk about, the class of shock, the guy presented with a pretty good blood pressure, even though he was bradycardic, severely bradycardic. He went from Sky B to Sky D, and then actually Sky E. He was in extremis during the procedure. The operator put in a Impella CP in the right femoral artery, and then started trying to do angiography and open his vessels. And what the operator did here, you see the Impella's in. You could tell by the dye contrast, he's in profound shock. We have the TVP in. There's some thrombus in the distal right, and what the operator did not take an angiogram of the first image before ballooning, which had occlusion of the proximal right. Not sure why they didn't do that. If you look at the left system, this is a very strange, but he has a very long left main. He has a thrombotic occlusion of the distal circ. You could see that, and of the LAD, which we'll show you with TIMI 2 flow. And here's his V-gram. So I'm not sure why we need to do a V-gram. We have a point of care echo. I suspect his filling pressures were very high. The concern here was maybe, complication of acute myocardial infarction. He had no mitral regurgitation, no apparent VSD on these limited angiograms. I'm not sure that we can make those diagnoses. Then you look at the right heart cath, and what you find here for the fellows is when you see a right atrial pressure above 15 in the setting of shock, particularly if the left side has been treated, you should be concerned. And here's a patient who's on max support of a CP, and he has a right atrial pressure of 25, so that's very concerning. His PAPI is 0.8. His cardiac power output is 0.32, despite the fact that he has a CP in at max support. So what do? This patient at the time has a CP in his right, and this is when I was called in for refractory shock. And if you see what's happening here, this was me trying to assess I wanted to escalate potentially to ECMO for biventricular shock. And if you look at his angiogram, he has severe PAD. On the right side, the CP is occlusive. They don't have an antegrade sheath in there, so this is going to cause limb ischemia. On the left, they have very bad PAD, small hostile iliofemoral disease with an occluded SFA. And let's go to the next slide. So what happened to this patient? Should we put him on bipella or escalate to VA ECMO? The guy has severe RV dysfunction. He's relatively young. He presented early. So we felt because of the severe peripheral arterial disease, it precluded the use of VA ECMO in this patient. So what we did was we got axillary access, took the CP out of the leg and put it in the arm. And then we put an RP in from his leg. So we decided to go for biventricular support with right side Impella and left side. We had a preemptive sheath, and then that way his legs were protected, and we anticipated he would be in here for a long time. This is just an angiogram showing you have a right heart cath in, we have an RP, and we have a CP. So, we're patting ourselves on the back, and here's what happens to this patient when he goes to the unit. If you look at his pulse pressure on the left with Impella CP Smart Assist, it's very narrow. And you can see on the right, we're able to get 3 liters of flow on the right, 3.3 liters on the left. And we have a mean arterial pressure of 69. So we think that we're out of the woods. But look what's happened to this patient. His urine output goes down. So he's hemolyzing also, most likely from the Impella. And more concerning is that his lactate is continuing to rise. And that's a really bad sign. And so we follow lactates closely because they dictate our therapy. In this particular case, let me show you what happened to his lactate on bipella. So when he presents, he has a lactate of 6.5. And after initiation of bipella, his lactate almost doubles. within 6 hours. And so you really have to do something, or oftentimes these patients won't survive. So we decided to escalate to VA ECMO. And what we were going to do is we took the Impella CP and we put it in, we put a 9 French sheath to peel away into the leg for a vent. And we cannulated the axillary artery for ECMO. So we took our Impella out of the arm, the 14 French, and we increased it to a 15 French axillary cannula. And you can see this is the femoral artery. This is a 2.5 liter Impella in as a vent. We ended up peeling this away, showing that we were non-occlusive. We had flow down to a profunda. His SFA was occluded on the right. And this is the return drain cannula for ECMO. Here's his arm, and we have a 15 French cannula arterial in the arm. So what happens on ECMO with this patient? We were able to flow at 4.2 liters per minute, and flow really was limited by our cannula size. We've done a couple of these axillary. The highest we put in is 17 arterial cannula, and that will increase your flow. This patient's PAPI improved significantly, and I'll show you what happened to his lactate. He did have a drop in hemoglobin requiring blood transfusion, which is not uncommon in the shock patients that require ECMO or Impella. We were able to get him off pressors, and look what happened to his lactate after initiation. So our peak was at 13.5, and you could see within 2 to 3 days, we normalized his lactate, which is a wonderful sign. And then we started to see recovery, biventricular recovery. So you see the yellow signal waveform is his right heart cath, and you can see pulsatility on the right heart cath. The red signal is the LV, and you can see we have biventricular pulsatility now. This is on post-op 4, and you can see the motor current looking good. We have a mean arterial pressure of 75, and we were using this as a vent, about a liter vent, because we didn't want the ventricle to distend. On our patients who are on Impella or ECMO, we do usually daily or every other day TEE to evaluate LV function. And what we see here is on post-op day 4 of ECMO and Impella, he's starting to have some recovery. You know, if you remember, he was 5 to 10, and now he has biventricular chamber recovery. We took him back to the lab to see if there was anything else that we wanted to, or we could potentially revascularize to facilitate decannulation. And what you'll see here is now he has TIMI3 flow in the circumflex, he has TIMI3 flow in the LAD, and he still has that distal severe RCA disease that we opted to leave alone. He was doing pretty well. So on day 8, we got him, we started him, he was on a little bit of dobutamine, positive inotrope, his lactate was less than 1, his LFTs had recovered, his renal function improved, he started making urine, and we had hemodynamically stable mean arterial pressure with low flows on ECMO. We have a weaning protocol here. We made a decision to decannulate. So how do you decannulate somebody on ECMO percutaneously if you have it in the axillary artery? And you can see here's our large cannula, and this is an angiogram showing that we had flow around this cannula. So this patient had a generous axillary artery. And what we did is we do what we always do. We get access from below. And this is something we're in the process of publishing is we did not have Preclose because this patient was a shock patient. And I didn't want to do any kind of post-closure because of how sick he was. So what I decided to do, and this has kind of been our standard now in our axillary ECMOs, because usually we're rapidly trying to do this, is I did an IVUS to size it. And I used the IVUS to size my self-expanding covered stent, and then I deploy it. And you can see here's a self-expanding covered stent, preservation again of the circumflex humeral and the subscapular artery. How do we know which size to use? Because angiographically, you can't afford to make a mistake. If you undersize a self-expanding stent, it's going to be a problem. So we just wire it. We're very proficient here at IVUS, like you guys' lab. And you could do this with the coronary IVUS that you have. And we use the IVUS to size our stent. In this particular case, it happened to be a 9 millimeter. And we put a 9 millimeter vibe on there. I think this one was a 9. We have to go back. Hemodynamics after decannulation. Look at his blood pressure now, 98/63, maps in the 70s. He's on very low doses of dobutamine. Subsequent events, his kidneys improved, but not enough. He required CRT. His native heart recovered to an LV function of 35 to 40, and he did okay. So if you look at this is a paper that we published actually this week, maybe 2 weeks ago in CCI, showing, and it's germane to this case. Should we be doing, is percutaneous large bore axillary access a safe alternative to surgical approach, cut down? And in this is a systematic review, we found that the complications were similar, and actually you had less bleeding if you did this percutaneously. But the advantage of this is how rapid you could deploy it. A surgical cut down takes a few hours by the time you get anesthesia, the team, OR time, etc. And by that time, your patient has expired. We published our experience on the use of the axillary artery for MCS and cardiogenic shock. And again, I think our average time was 12 minutes from access to LV unloading. I've had the opportunity to go all over the country and actually all over the world. I've been to Europe and the Middle East, and I'm happy to say that this is a very teachable technique that most cath labs in this country we have the tools and the skill sets to do. The most interesting proctoring I've done is there's a gentleman here, you could see him, who called me. I never met him, but he knew me from social media. He got a hold of me in the middle of the night. He had a patient with critical aortic stenosis and in shock who did not have suitable iliofemorals. And what you'll see here is on FaceTime, here's his angiogram. Happy to report that he was able to do this in the middle of the night, having never done it, being virtually proctored. And I think that speaks to how really teachable this procedure is. And I think that this is a skill set that all of us in the interventional community can develop and hone, and hopefully and potentially save your patients or help them through some procedures. So with that, I would like to thank my dear friend Azim for the opportunity and the honor to present to you guys. If you have any questions, please let me know and I'll do the best I can to answer them. Thank you.
Amir, thank you. I'm kind of speechless still from that last case.
Yeah. We got lucky.
What an incredible case. And it just shows, if you have the skills, and the support team, and I think, not to forget how important having the support team, the ICU and the care afterwards can make a difference in a very sick patient. But I think, both me and Juan was saying, one of the great things about this lecture series is just the opportunity to really go in depth into a subject. And it's probably the best PERC auxiliary talk I've heard. I've heard Uli Schaefer talk about it. That's what I learned to do PERC access from, was Uli. But this is even better because I think you've taken it now to a completely different level. It's very much more scientific and didactic. So really fantastic.
No.
Well done.
Well, thank you so much. I think it's underutilized. I didn't get a chance there's some data I wanted to put in there from the TCT registry where it showed when they looked at alternative accesses, and they showed that PERC axillary was associated with the highest stroke rate. It came in at about 6%. But what people don't talk about is the people who are selected for axillary are people who are at high stroke risk to begin. So there's a lot of confounders and a lot of bias. What I would say to you is that if maybe we should be doing other things such as, a stroke prevention, some of the devices, Sentinel, et cetera. But I think, I don't think it's fair to the technique or to the procedure. A lot of people now are not using it because of that data, and that data just for the fellows to know that there's a lot of confounders and biases. And I think this is, if done properly, this is a safe, good strategy for your patients.
Right. So I'm sure we both have a lot of questions, and there may be questions from the chat. So maybe I'll start. When you're doing an axillary large bore access and you're going to leave the device in, whether that's Impella or ECMO, do you always do a final angiogram to make sure there's flow distally, so you know whether to put a bypass in? And do you do that for the femoral too?
Yeah, that's a great question. And so I'm probably the most pro physician that you'll ever meet, when it comes to, taking care of doctors and protecting us. And what I will say, and I say this a lot when I talk to the fellows about large bore vascular access, I think it's irresponsible if you leave a large bore access sheath in someone and then send them to the unit. You have to, I think it's standard of care that you have to demonstrate flow going down that extremity. So if it's in the femoral and you have an Impella in there, you have ECMO, you have to show it. And the reason I'm very adamant about that is by the time it's recognized that the limb is cold, number one, it's much harder to deal with. And number two, oftentimes these patients can lose their limb. And limb loss in the setting of shock is associated with almost 100% mortality. So I think it'd be malpractice if you don't demonstrate flow to the limb. That being said, in an axillary and in femoral, in axillary, you always have to have your radial before you start your femoral. So you do your angiogram, no problem. We're a little bit occlusive. You hook up to the radial and you're done. In the femoral, it's a little bit different. In femoral, and 100% of my ECMO patients, we preemptively put in an anterior access point as a conduit because oftentimes they're going to be occlusive. With Impella, it's a lot different. You don't have to do that. You could do it post hoc because you could peel away the sheath if you're occlusive from 14 to 9. So, but with ECMO, I think it's incumbent that you prophylactically perfuse the limb, and with axillary, always have your radial.
Yeah. So maybe two questions with that. With the femoral, for your antegrade stick and the perfusion, what do you use, 4 or 5 French?
Oh, that's a great question. So people always think that it's the French size. It's not. You know, out of everybody who's listening to this, I see that Vlad Janine is there. He was a good man. He trained me when I was at Lenox Hill. He's a lot smarter than me, but I'm not a physicist, you know, but what I remember didn't take many physics classes, but this diameter of the tubing, the connection and the length of the tubing. So what you want is a shorter tubing, but it doesn't matter if you put a 5, 6 or a 7. So in my particular case, I always put the smaller one, you know, I'll put a 5 French in because it's easier to deal with hemostasis. If you have large patients with big pannus, then I would use an arrow sheath because the plastic sheaths have a tendency to kink. So if it's a thin patient, I just put a standard 5 French. If it's a bigger patient, I'll put whatever short arrow that we have in our lab, a 5 or a 6.
Okay. You know, another question, this came up last week. We were talking about a case with the team, was, you know, a lot of us are using single access. I'm sorry, I'm going a little bit away from the auxiliary. No, you just have so much experience and we want to use it. A lot of people are using single access for the Impella and the PCI, all right? But one of the limitations then is, how do you know you have final flow distally?
Yeah.
Because, you know, you can do, you know, once you have the sheath in, you can still do an angiogram, right? You can put a pigtail up. And if you don't see flow, the first thing you're going to do is pull away the peel away, right? Yes. Because you may just pulling the peel away have flow, but then how do you know you have flow? Because now you don't have access anymore.
Absolutely. So, you know, to be very honest with you, I've been one of the slowest adopters, and usually I'm very early on adoption curves of the single access for that reason that you pointed out. And the people who advocate it, like Jason and Dwayne, who kind of come up with it, you know, their point is well taken that you mitigate the risk of a secondary access point. So my take on it is the other alternative access point you're going to have potentially could be a radial, which is not a lot of risk. And the advantage of having a second access point is exactly your point, Azim. In my opinion, a patient should not get off the cath lab table who had a large bore access until you've clearly defined by subtraction angiogram that the patient does not have extravasation of contrast, does not have thrombus or flow limiting dissection. And the reason I say that is if those complications are recognized early, they're very easy to be dealt with percutaneously in the cath lab and usually of no clinical consequence. Now, however, if they're recognized late, it becomes a much bigger problem. And so I totally 100% agree with you. That being said, we may not be right. Maybe the limitation of a second access point based on complication risk is justified, but I have not changed my practice because I'm not convinced.
Yeah. I must admit, I adopted single access, and now I'm moving back because my secondary access has always been radial, left radial. And it's you know, to go down from the left radial to the end and do your angiogram.
Beautiful.
And the complication is pretty easy.
Correct.
Juan, do you have any questions?
I'm fine. Okay. Phenomenal. Congratulations. A great talk.
No, thank you, Juan. Thank you for having me. I'm very, very honored to be here.
A couple of other questions. Another other question. You know, we've been getting a lot of requests from our heart failure team. We have a very active heart failure team that we collaborate with. They do a lot of transplants and VADs. And recently there's been a lot of requests from them to put in auxiliary balloon pumps.
Okay.
Which we've been doing, you know, and following really your advice on access, that's how we've been doing. One of the issues we've had though is migration of the balloon pump.
Correct.
That it starts coming upwards into the arch. Any experience or any advice?
Yeah, so to be honest, to be honest with you, I have never put in an axillary balloon pump, so that's full disclosure. The second thing I would say is that for the heart failure colleagues, so one of the limitations that I think that we need to talk about about axillary access for at least for the large bore population. And Jamie was the first one who recognized the signal. We need to publish it, and I've seen it in several of my cases. Is when I used to think that this would be a great access point for our heart failure colleagues, but what I'm finding, at least as it relates to Impella, usually at about 96 hours, even though you have flow around it, we're starting to see thrombosis at the access site. And so what we're doing now is we're trying to get the same thing with ECMO. And so what we're trying to do, at least with Impella, is if we're finding out that the patient's going to require it longer than 96 hours, then I'll have a surgeon come in and do a cut down on the other side, and we'll take the Impella to that side. So the surgeons, I'll give them that. They do a better job at that because their conduits, for whatever reason, their grafts don't seem to thrombose. But even when we leave these in here, we're seeing thrombosis. I'd be interested from your heart failure colleagues or you, Azim, when you're leaving these balloon pumps in, how are you taking them out, number one? And number two, when you're doing your final angiogram, when you're taking them out, assuming they've been there a few days, are you noticing it with the smaller bore pumps, or are we just seeing that with Impella and ECMO?
Yeah, so I'll respond to that. So we take them out with a similar technique you do, in the sense that we'll get femoral access, go up from the femoral, cannulate, put a wire, and do balloon tamponade.
Okay.
We then closing them usually with a single ProGlide at the end, because it's an 8 French sheath.
Correct.
That really hasn't been an issue. And then doing a final angiogram. One of the things we've learned is that the newer fiber optic balloon pumps tend to migrate more because they're not as stiff. So we've ordered some of the older ones. And the second thing we're now doing is we're actually putting in a longer sheath, right? So whereas before we put in a very short 11 centimeter sheath, now we're putting a longer sheath that goes around the subclavian into the arch, so that it kind of almost acts as more support to hold the balloon pump downwards. In the ones that we've pulled out, or the ones that our surgeons have removed, they've not seen a lot of thrombus. So I think it's particular to the larger bore access.
Maybe you're probably right.
Any thoughts? I mean, there was some excitement about Manta for axillary. Your good friend in Rotterdam was one of the people who was saying it was great. Well, our good friend, actually. Nick was very excited about it. Any thoughts? I've been less excited, particularly for the axillary. But any thoughts?
Yeah. So in full disclosure, Nick and I, we did our fellowship together at Lenox Hill, and Vlad knows a lot of the stories. I'm married now and I have 2 young girls, so don't believe anything that Vlad says about it. But no, but I would not recommend the use of Manta, to be honest with you. Number one is, if you look at the Manta and their pivotal trial, these patients had advanced imaging. Okay, so that's number one. Number two, if you ever try to use Manta without advanced imaging, you have to use the depth locator, and oftentimes these are going to be shock patients, and to do that post hoc has been challenging. Dwayne Pinto and Nick have published a limited series of 2 or 3 patients where they've done it post hoc, where they use a depth finder using ultrasound. I would not recommend the use of Manta in the arm. There's very little data. Nick does have one published, a case where he did it, but I just think the stakes are too high. Arm ischemia or thrombosis in the arm, or failure to get hemostasis could be catastrophic for people, particularly in their dominant arm and even their non-dominant arm. So my recommendation is do what's tried and true. You got good access with Preclose. We have a tremendous experience, balloon tamponade, and in worst case scenario, it's not the worst thing in the world to put a Viabond there. And if you look at the patency of Viabond, since we've been doing axillary, because it's such a large vessel, the patency rates are actually very high. So it's not, and the other thing, it's not a flexion point. So the axillary artery, the durability of that, we suspect is going to continue to be very good.
Yeah, absolutely. I like the idea of a Viabond if you're going to do post-closure for the axillary. I mean, we all do post-closures in the femoral, and I think that's fine. It's a different beast, but I think
exactly,
I agree with you. The axillary subclavian is just, such a fragile artery. You have to be more respectful of it.
I agree with you.
Listen, Amir, we covered the hour. It's 8:30 exactly. This has been a phenomenal talk. Once again, we really appreciate you taking the time.
Oh, it's my pleasure.
We all learned so much. We're going to get you in next year again to talk more about mechanical support, which I know your other great area of interest.
My pleasure. Thank you again. It's an honor. So to you and Dr. Granata, thank you for having me. And if you have any questions from the fellows, I'm always very, very easy to get a hold of. So thank you guys. And if anyone's ever in Detroit, give me a call.
Yeah, will do.
Thank
Take
you,
care.
Mayor. Bye.
Bye-bye.
Bye-bye.